So today I'm going to talk on the limb lengthening and reconstruction using this Precice nail, which is the magnetic internal nail. This technology is the same that is used for the magic rods for the spine. There are many limb lengthening nails available and been there for a while, for a couple of decades, like Fitbone and ISKD. But this nail is very user friendly. Now, traditionally, we used to do limb lengthening in Sheffield using external fixators, and for femur, you can see this is a case of a PSO, and the amount of hardware and the problems that you can have with your clothes, it can be quite actually challenging for them to move around, and the pin track problems that you can have with this. So what is this nail? This is a telescoping nail. It's got a motor inside the nail here, and this lengthens as the motor is powered up by an external magnet. Now it's titanium nail, and it's a typical locking screws are not the traditional locking screws. You can see that the threads are near the near cortex, they hold it. So it's like a bolt, but it's a modified bolt. So the antegrade nailing, you can have two entries. One is the piriformis entry, and the other one is the trochanteric entry. And we all know with the problems of AVN on the femoral head that you could get issues here. So therefore, a trochanteric entry is a good entry point to start off with. You have to do a planning in ABC. You have to see how much is the desired lengthening that you require, 8 centimeters, and then the osteotomy level you plan out, and then the amount of arm that is available here, 3 centimeters. And then you have to also compute into your calculations that how much lengthening. If you're doing 5 centimeter lengthening, then you should have enough of the nail inside the outer sleeve of the nail so that it really does not run out of length and run out of the motor, because you have to give enough length to the motor. So this is the entry point, and this is the osteotomy level for this nail, and this is the distal end of the implant. So typically you enter from here, you do an osteotomy, and you fix it with this type of bolts. The distal locking is done as freehand. The only thing here to mind you is that in the normal traditional locking nails, the hole is a little bit bigger than the screw. Here it is almost the same size. It's only 0.5 millimeter wider. So it is the aiming is even more. You have to be even more precise and skilled actually to get your screw into these holes. So this is the typical magnet here. You can see this is the magnet, and this is the gearbox here, and this is the lead screw. So this is the center of the magnet, and you have to have the center of the magnet near about the osteotomy site. This is the external remote control that you will use, and we give it to the patient. Actually, it's the big suitcase that they go home with, and we train them how to use this. This is a typical pre-lengthening screw space. So what we do in the OR, in the operation theater, is that after we've done this, we keep the patient draped, and then we put this onto the, say, thigh or the leg, and we actually power the magnet, and we see that the distraction is happening, and we do it until 1 millimeter distraction has happened, and the guide for that is this disc here. You can see that this will widen up, and when you see on the fluoroscopy that this has widened up, that means that the osteotomy will work, because you don't want to be in a situation where you send home and then this is not working. So post-op follow-up is done. Latency period is 7 days. That is, distraction is done in 3 sittings, 0.33 millimeter 3 times a day, and you build this up into the software. Monitor every fortnight. So we call them every fortnight into our clinic, outpatients clinic. Consolidation, as usual, is double the time of the distraction, and you have to have physiotherapy for the knee movements, and they are kept non-weight bearing until 3 cortices are seen. This is not like a traditional trauma nail where you can leave them free to mobilize, because it's a flimsy metal nail, titanium nail, which is very hollow to hold the motor. So you have to keep them on crutches, touch weight bearing. So this is a typical case 1. The patient had a trauma when they was age 11. He had smashed up actually condyle, and the growth plate was arrested here, so we obliterated the growth plate. The patient was shot here. So patient initially had Nancy nails, of course. The Nancy nails were removed in 1 year. The residual deformity was 4 centimeters. So pre-op planning, you calculate the intramedullary canal because you need to know the sizes of the nail and measure the canal at different levels because you need to ream, and you need to ream a good deal more, 2 millimeters more than actually the nail, so that it slides in. So after measuring the canal in both the planes, we do the planning on a trauma CAD, and you see the proximal locking screws, the distal locking screws, the osteotomy side, the motor, everything is computed both on AP and lateral plane. And we came to the conclusion that it will require 8.5 millimeter nail, and the length of the nail would be 230 millimeters. So you can imagine that the nail is quite thin in diameter. So this is the typical entry reaming, and this is the percutaneous osteotomy is done from a small incision, and the osteotomy is done with the guide wire in. This is like a Elizarov technique of osteotomy. This nail is, of course, not cannulated, so we have to remove the guide wire and then slide this whole nail in, and then you do the distal locking. So this is magnetic lengthening intraoperatively. Then we see that the distraction has happened here. The disc is opened up here. So after 6 to 7 days of latency, we start the distraction process. And as I said, 0.33 millimeter a day, the distraction starts. And then finally union at consolidation day 120. You would always know that with fit bone and with other nails, the ISKD, when you do a lengthening in the femur, it is on the anatomical axis that you're lengthening, not on the mechanical axis, and you're going to get valgus. Because this nail has got a motor and all, we have not yet used the polar screws, but we may be starting using polar screws for longer lengthenings to get a little bit of a eccentric placement of the nail. So inevitable valgus, as I said. So case 2 example, 16-year-old male, congenital longitudinal limb deficiency, fibular hemimelia, 3 centimeters short on the on total. Pre-operative planning was done, computing was done, and then the nail sizes was determined, and distraction was done 1 millimeter a day with locking, and there you go. So the final result, and in this case the mechanical axis was good. So this is a case of osteogenesis imperfecta, 4 centimeters short. The patient had got a Sheffield rod here. We have a rod which is a telescoping rod because this rod actually lengthens with the growth of the bone. But the patient was short, and so then we removed and changed it to a Precice nail. And then after the lengthening and consolidation. So before lengthening, post Precice lengthening, you can see the axis. Correction. So retrograde nailing, it is also, you can use this as a retrograde nailing. You have to do a reverse planning for the length of the nail, the distal end of the implant and the proximal end of the plant. Remember that when you're entering, you have to make a bigger hole. So the surgical steps are similar: joint line, get to the notch, do the osteotomy here, and do the proximal locking. Proximal locking can be done in both planes, in the coronal or the sagittal plane, like any other retrograde nail. Locate the magnet. You have to locate the magnet and plan the osteotomy, and a 1 millimeter distraction on the table. Now the magnet, to distract 1 millimeter, actually it requires 7 minutes. So you have to keep the magnet 7 minutes, and it makes this funny noise. And after about 7 minutes, the 1 millimeter distraction is achieved. This is a case, for example, a patient who had a post-septic arthritis of the left hip. So we plan to do a Elizarov hip reconstruction or pelvic support osteotomy and distal lengthening. Did the first stage and put the titanium 2 plates here. We use the titanium generally, although I've used steel plates as well a couple of times, but we want to use titanium because we don't want to interfere with the magnet when we do the distal lengthening. And then the distal retrograde nail was inserted here. And you have to calculate that you have enough distance so that you can fix your nail. And then the lengthening, and you can see this whole motor here. So gradual lengthening, over time, and quality of the regenerate is good. And finally, and lengthening end of consolidation. You can do the contralateral if you contralateral epiphysiodesis to modulate the growth. So demographics in our CH we did about 26 nails, 16 were antegrade and 10 were retrograde, and lengthening achieved was on an average 32 millimeters. This was the group of patients with congenital longitudinal limb deficiencies, hemihypertrophy, OI, DDH. So mixed bag of actually cases here. So what are the you can get complications, you can get back off of the screw because this is not a very good thread actually to hold on. So if patient starts bearing, this fixation it was slightly off because titanium is a bit of a unforgiving metal, so it has got elasticity. So you have to be very careful when you're doing this using the jig. And so this other complication is, this was in the antegrade nailing, no ACL, ball and socket, ankle joint, and the nail started bending in this case, you see. And therefore we had to stop the lengthening and put in a revised trauma nail, and then finally patient went on to consolidate. So it's a safe and reliable procedure. Of course, you have to watch out for complications. Remember that this nail has to be removed as well because it's a magnet, and patients for any other reason requires MRI scan. Then you may want to remove this because we don't know what will happen to the motor if the patient goes into the MRI scanner. Thank you so much.